尊敬的各位专家，上午好。Good morning, honorable experts. The next speaker is Professor T.C. Li. T.C. 李教授呢是香港中文大学妇产科学系教授，是香港中文大学威尔斯亲王医院生殖医学及外科主任，是谢菲尔德哈莱姆大学生殖医学及外科名誉教授，是首都医科大学客座教授，山东大学、香港大学名誉教授，是亚太生殖会议专家组成员。今天 T.C. 李教授带来的题目是 Modern Management of Recurrent Miscarriage。下面请 T.C. 李教授为大家授课。
On the update of the management of recurrent miscarriage, and I hope to cover the following 5 areas. Firstly, the terminology and definition, followed by management of the index miscarriage, then management before next conception occurs, and finally management of the future pregnancy and some aspects of prevention. I hope in the process I would cover the discussion of the following controversies. Definition, 2 or 3 miscarriages. Index pregnancy, carrier type or not. Before conception, how much to investigate. In the next conception, use progesterone or not, and use immunotherapy or not. And finally, is PGTA worth the while in preventing miscarriages? First of all, about terminology. It's helpful to know that international community now wish to define miscarriage as the spontaneous demise of an intrauterine pregnancy, whereas early pregnancy law referred to the spontaneous demise of an intrauterine pregnancy, as well as pregnancy of unknown location. So it has a broader definition. Abortion really should be confined to the use of, to refer to termination of an unwanted pregnancy when it is still going. So definition, 2 or 3 miscarriages. If you look at the various organizations, ESTRI 2006 and RCOG 2011, both refer to 3 or more miscarriages. More recently though, ASRM and both ESTRI updated guideline in 2017 refer to 2 or more miscarriages. But does it matter how it is defined? I suppose yes, in terms of research or academic considerations for the purpose of a clinical trial, for example. However, on a pragmatic point of view, the question is when to start the investigation. So with that in mind, it is useful to know that it really ought to be individualized. Some patients need to be investigated earlier than others, and clinicians should use their own discretion. And it is helpful to consider selective investigation for 2 miscarriages and perhaps reserve the more comprehensive investigation for 3 or more miscarriages. And finally, it would be helpful to point out that young women are more likely to have a treatable underlying pathology, and so should be considered for early investigation. So managing the index miscarriage, shall we do karyotyping or not? Well, there are 2 schools of thought. Those who say no because it costs money and it does not predict what would happen in the next pregnancy. Those who say yes would say our patient wants to know the answer, and it helps to confirm the underlying cause, and it may also help the management of the next pregnancy, for example, whether PGTA ought to be considered. So the guideline of ASRM say karyotyping analysis of POC is useful. Our COG guidelines say yes. However, ESTRI in 2017 say that it is not routinely recommended, although it could be performed for explanatory purpose. If you do karyotyping in a spontaneous miscarriage, you will find that on average 45% of cases would have an abnormal chromosome, mainly aneuploid. On the other hand, if you do the karyotyping analysis in recurrent miscarriage women, you expect an average 39% chance of abnormality, which is even lower than that of the sporadic miscarriages. But not only that, if you look at the Japanese data, they found that the greater is the number of previous miscarriages, whilst they are more likely to have miscarried again, they are also more likely to have normal karyotype, or in other words, less likely to have abnormal karyotype. These data suggest that the higher order miscarriages, the likelihood of maternal uterine factor is increased. So in performing karyotyping analysis, one should realize that there are two potential problems. One is maternal contamination, which occur in about 20% of cases. To overcome this problem, one should wash away from public so it would go to you without any possible conception or state line. Or the state line conception out being washed away. And then again, of course, state line should. And finally, you will see a very clean loops of villi. That's all that you need, a small piece, but a clean piece. That's what a laboratory needs. But the second problem is culture failure, which also occurs in around 20% of cases. To overcome that problem, obtain the product of conception as soon as miscarriage is diagnosed, and consider using molecular genetic techniques rather than conventional karyotyping. Well, the other important consideration whether to do karyotyping or not is, what do our patients think? Well, recently my PhD student, Kosi, helped me to do a survey on 100 women who had a miscarriage problem, and asked them whether they would like to have karyotyping analysis of product conception, given the cost and also given the S3 recommendation that it might not necessarily help them with the management and might not be able to predict what might happen in the next pregnancy. So I have to say the vast majority, 90% of the women, would like to know the answer. So the S3 guideline 2017 did think about this, and I think therefore they put in this phrase, it could be performed for explanatory purposes. And that is, if the patient wishes to know the answer for the underlying cause of their miscarriage. The next area is the management before the next pregnancy. The question is, how much investigation do we need? It is really helpful to understand that the recurrent miscarriage population is rather heterogeneous. There are different underlying causes, and therefore investigation ought to find out the specific underlying cause for each couple before specific treatment could be offered. First is uterine factors, which account for 15 to 20% of cases, and it includes congenital anomalies like a septic uterus, or acquired condition like fibroid, polyp, adenomyosis, or intrauterine adhesions. Literature data suggests that the prevalence of congenital uterine abnormality in the general population is around 4.6%, and that in the recurrent miscarriage population is increased by about fourfold to 18.2%. The S3 consensus on diagnosis of female genital anomaly stated that 3D is the recommended modality for diagnosis. And here are some examples of 3D coronal view of the normal uterus and the T-shaped uterus, the septate uterus, unicornuate uterus, and bicornuate uterus. I have come across several cases of congenital uterine anomaly notably septum uterus, that been missed by my colleagues in the process of the investigation, which is rather embarrassing. Had they performed a routine ultrasound 3D examination, I think it would avoid the embarrassment. Hysteroscopy, though, remained the gold standard of diagnosis for acquired conditions like Ashman syndrome or intrauterine adhesions. How do we manage structural uterine anomalies? If there's a septum, I will remove them. I don't remove every single septum, but when it is associated with recurrent miscarriage, I think it's a good indication for intervention. By uterus, I would consider megaloplasty in high-order miscarriages, but not just for 3 miscarriages. For example, in 4 or 5 miscarriages. Unicorn uterus, I would consider lateral wall incision in high-order miscarriages, again 4 or 5 miscarriages. Submucous fibroid, I would always remove them. Intramural fibroid, I would consider removal if it is more than 4 centimeters when it is associated with recurrent miscarriage. Intrauterine adhesions, I will remove them. Polyps, yes, I will remove them. The septum is a very controversial area. Though in the S3 there is a webinar at the end of October on the need or no need for septum incision. For those of you who are interested, perhaps you can join the debate in the webinar. This is a diagrammatic representation of a Strassman's megaloplasty, which is indicated for bicornuate uterus and associated with recurrent miscarriages. So in essence, you make a horizontal recurrent uterus was pioneered by Professor Tsai in Fuxing Hospital in Beijing. They reported a cohort study, like so, when you resect the lateral wall, the medial wall of unicorn uterus, like using a hysteroscopic loop diathermy like this, Professor Tsai reported a significant reduction in miscarriage rate based on a cohort study of 18 subjects. As for the next set of investigation, acquired thrombophilia, it is estimated to occur in 10 to 15% of women with recurrent miscarriages. The recommended screening tests include lupus anticoagulant, anticardiolipin antibody IgG and IgM, and anti-beta-glycoprotein. Good to remind ourselves that to fulfill the diagnostic criteria for APS, you need clinical criteria and laboratory criteria, and both criteria must be met. I should like to remind you that as for the clinical criteria, it's not just 3 or more unexplained miscarriages before 10 weeks, but 1 or more unexplained death of a morphological normal fetus, for example, late miscarriage, would warrant the clinical criteria, would fulfill the criteria. 1 or more preterm birth when it is associated with hypertension or placental insufficiency is also fulfillment of a clinical criteria. Vascular thrombosis is another one. Laboratory criteria, I think we all know that it needs to be positive on 2 occasions at least 12 weeks apart. The third group is about inherited thrombophilia, which occur in less than 3% of cases, including factor V Leiden, prothrombin 20210 gene mutation, protein S and C deficiency, and antithrombin 3 deficiency. ASRM and S3 say no need to screen. RCOG say that if there is a second trimester miscarriage, then testing ought to be offered. Another group, endocrinology, contribute to about 10% of recurrent miscarriages. The consensus is that thyroid function and thyroid peroxidase antibody ought to be tested, but as for prolactin and blood sugar, hemoglobin A1C, there is no consensus. Another group, parental genetic factor, literature data suggests that balanced translocation occur in one of the parents, though the ASRM suggests that parental karyotyping ought to be conducted, and S3 say, on the other hand, should not be performed on a routine basis. LCOG says that it is indicated only if cytogenetic analysis on pregnancy tissue of third and subsequent loss reveal unbalanced structural chromosome abnormality. The LCOG guidelines specifically mention the reason behind their recommendation being cost effectiveness, consideration from the NHS point of view, quoting that their data show the prevalence of 2%, and it costs too much money to screen for one case. I think though the landscape is going to change because of this publication last year, a joint study performed by Professor Chen's group in Shandong and my colleague Professor Richard Choi's team in CHK, they found that using modern molecular genetic techniques, genomic sequencing, they found that more than 10% of women with recurrent miscarriage would have subtle genetic abnormalities which might benefit from personalized intervention, providing a strong argument to do genetic analysis on the parents. And the group is about infection. ASRM, S3, and LCOG both, they all say no need to screen for infection. However, there are interesting development with regard to two topics related to infection. One is chronic endometritis. Our own study in CHK found that the incidence of chronic endometritis in women with recurrent miscarriage was twice higher than that of the fertile population. The second is microbiome study. Molecular study of the microbiome of the uterine cavity seem to suggest a role played by infection in recurrent miscarriage. And for young doctors wishing to do a PhD or some interesting research, watch this space. There will be a lot more data coming out from the literature in the next few years, I believe. Next group, immunology investigation. I think it is agreed that other than the lupus anticoagulant, IgG and IgM, anti-cadolybin antibody, and anti-beta-2 glycoprotein, viral peroxidase antibody ought to be tested. But other than that, there is no consensus on whether additional immunological testing is warranted. Uterine natural cell, the number in peripheral blood, cytotoxicity in peripheral blood, and uterine NK cell were considered not recommended for testing by S3. LCOG considered uterine NK cell an interesting area and remains a research field. I have to say that the uterine NK cells is really a rather special area. I have been conducting research myself into this topic for over 20 years. There is good evidence that uterine NK cells are directly involved in implantation. No doubt, they're present in abundance at the site of embryo implantation. Several clinical studies have reported on an increase in UNK cell density in the women with recurrent miscarriages. If you do wish to study UNK cells, the specimen ought to be precisely timed to say H+7, because there's fluctuation of NK cell in the luteal phase. If you don't time it, you can't interpret the result. My colleague, Professor Queenby in England, conducted a randomized controlled trial on the use of prednisolone to treat women with high NK cell. The study was underpowered. It did suggest a possible benefit, but really it was insufficient to have a firm conclusion. I have to say, despite my interest over the years, that UNK cell testing should remain part of a research program and not ready for routine testing. Cytokine, not recommended by S3 and LCOG. HLA, not recommended. other immunology investigation, including anti-HY immunity, ANA and anti-HLA antibodies, and so on, numerous other autoantibodies, they are not recommended for testing. Finally, we should understand that an unexplained recurrent miscarriage occurs in about 40 to 50% of cases. A significant proportion of these women, the underlying cause is due to sporadic or randomly occurring events such as aneuploid embryo. The main point is, following careful investigation, one would expect that 40 to 50% of cases will remain unexplained. In this group of women, what is needed is reassurance that there is a 70% chance that should they conceive, they will be successful. And what is needed is honesty in explanation, and what is needed is supportive care. What is not needed, however, is a desperate search for an unproven cause in this group of women, which would generate more and more anxiety. So investigation, how much shall we do? I would say no less and no more, just the right amount. And I would say over-investigation is usually a sign of lack of confidence or inexperience or greed. Fourthly, management of the future pregnancy. There are two debates. The first debate is progesterone supplementation, yes or no? Well, there are several possible beneficial mechanisms of progesterone supplementation. Namely, some women may have progesterone deficiency. Progesterone is among vitreal relaxant, and it might also have immunomodulatory effects. So let's look at the randomized control trial. There are two well-known randomized control trials on the use of progesterone supplementation. The digesterone study in 2014 said, yes, let's give progesterone because it works. It reduces miscarriage rate. But the following year, 2015, a PROMISE trial published in the New England Journal said, no, it doesn't help. So who is right and who's wrong? What shall we do in clinical practice? I think the best way is to look at the details and do a head-to-head comparison of the two trials. So the PROMISE trial and Indian trial are both conducted between 2010 and 2013. The PROMISE trial was conducted in 36 sites in the United Kingdom and 9 sites in the Netherlands, so really a multi-center study. Whereas the Indian trial was conducted in a single center in New Delhi. The PROMISE trial uses vaginal micronized progesterone, whereas the Indian trial uses oral digesterone. The PROMISE trial recruited 836 patients, which is more than double than that of the Indian trial. And the PROMISE trial recruited women much earlier on, as soon as they have a positive pregnancy test. Whereas the Indian trial recruited patients quite a bit later. They recruit them at the antenatal clinic when they may be up to 8 weeks pregnant by then. The primary endpoint of the PROMISE trial is live birth after 24 completed weeks of gestation, whereas the Indian trial is miscarriage before 20-week gestation. So what did they find? Both studies, interestingly, found there's no difference in live birth rate. However, as regarding miscarriage, the PROMISE trials say there is no difference in miscarriage rate, and both occurring around 32-33%. The Indian trial, the digesterone trial, suggests, however, that when you're treated with digesterone, the miscarriage rate drops to 6.9% compared with a placebo of 16.8%. The mean gestation at miscarriage was reported at 7.1% to 7.3%, whereas the Indian trial did not report this. So what conclusion can we draw? I think we should say that design, recruitment, sample size, execution, and analysis of the PROMISE trial all appear to be more superior than that of the PUMA trial. It is generally accepted that some bias did exist in the COMA trial. So the debate of progesterone supplementation in the prevention of recurrent miscarriage will continue for some time, but the balance of evidence at present is against routine use. So that is what Ashley say, insufficient evidence to recommend the use of progesterone. RCOG 2011 say there was insufficient evidence to evaluate the effect, whereas the 2020 version, it is still in a draft form, but I think it will say something like progesterone supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy, but not routinely. So the next debate is about immunotherapy, yes or no. Well, there are a number of immunotherapy offered by various colleagues: lymphocyte immunization, prednisolone, IVIG, intralipid, GCSF, heparin, and the S3 say no, 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 no to all of them. RCOG say no, no, and didn't comment on the four specifically. But by and large, immunotherapy is not recommended except as part of a research program. The reason being, if you look at the published randomized placebo-controlled trials in this slide, which is quite busy, I just want to show you that there are only 3 studies showing a possible benefit, whereas the more recent study, 10 of them, showed that there was no benefit with all these various immunotherapy, including IVIG, glucocorticoid, intralipid GCSF, and lymphocyte immunization. So I guess the majority of you would say no, because immunotherapy is not recommended by international societies. There's insufficient evidence of benefit. The vast majority of specialists do not offer it. Live birth rate without treatment is 62% anyway, so why bother? And you might say honesty really is the foundation of clinical practice, and these immunotherapies are not without side effects. Well, this slide reported on some of the adverse effects of the various immunotherapy. So lymphocyte immunization may cause infection, possible long-term risk of hematologic malignancies, and risk of neonatal autoimmune thrombocytopenia and erythroblastosis fetalis. Prednisolone may cause preterm birth, diabetes, and hypertension. IVIG may cause skin rash, transmission of viral infection, and it's rather expensive. Intralipid is not totally safe. It might cause thrombophlebitis, allergic reaction causing acute lung and kidney injury, may even cause cardiac arrest, headache, dizziness, flushing, drowsiness, nausea, vomiting, and sweating. GCSF may cause dyspnea, chest pain, and hypoxemia. Well, I guess some of you might say, yes, I do offer immunotherapy because my experience suggests it may work. And that absence of evidence of benefit does not really imply evidence of no benefit. Then you might think it is better than nothing, and patient wants it, feeling better with it, and also that the hospital is happy for me to do it. Well, what is the answer? I think the answer is making a fine balance, clinical freedom and responsible practice. I think with that, then there could well be progress. So the guidelines said is not to offer treatment unless in the context of research. So the answer is really, if you do offer the treatment, it ought to be part of a research program. It could be RCT. It might not need to be RCT. It could be a well-planned cohort study. Patients need to be informed about the nature of the treatment, and you ought to collect essential clinical data and analyze them regularly to see what result you have got and if it is worth to continue with the treatment. And you should endeavor to add new knowledge to the literature. Finally, about prevention. Would PGTA in women with recurrent miscarriage be useful? Yes or no? Well, a lot of people quote this paper an intentionally treat retrospective analysis of women with recurrent miscarriages using the PGTA program. So here is the results. You treat them with PGTA, number of oocyte retrievals, and those without PGTA but trying natural conception. And the study reported that the miscarriage rate in the PGTA group was 14%, which was a little lower but not significantly lower than that of the no PGTA group of 24%. And the live birth is very similar. As to support not to use PGTA. However, the devil is in the details. When you look at the supplementary figure, look at the difference in miscarriage rate in different age group, you'll find that in older women, there's a big difference in the miscarriage rate. The miscarriage rate in the older women is 4 times or more higher than that of, in those trying naturally is 4 times higher than that of women undergoing PGTA. Whilst it is not that, I think it is clinically very significant. The same when you look at the stratified live birth rate. Even the raw data suggests not much difference in live birth rate. When we look at the age stratified live birth rate in women who have undergone PGTA, you see the live birth rate is quite a bit higher than that of the woman who attempted natural conception. Although the difference is not apparent, not obvious in the younger age group. So the answer to that question again is PGTA perhaps will not be routinely indicated, but it might well be useful in women over the age of 35 years. But finally, prevention of uterine factors, I think will be helpful to avoid surgery, avoid curettage of the graphic uterus. When you do need to do surgery, be gentle, use the minimum amount of energy, mechanical, electrical necessary to reduce tissue injury, and precision surgery, use ultrasound guidance to confirm the uterus is empty to avoid the need to do check curettage. So if I may summarize what I just said, definition, understand the rationale behind the different definitions used by various international bodies. In that miscarriage, karyotyping should be offered for explanatory purpose. Before the next pregnancy, appropriate investigation, but not overdo it. Next pregnancy, increase surveillance and supportive care, or what we call tender loving care. Progesterone has uncertain benefit, immunotherapy has no proven benefit. Prevention, PGTA has a role in selected cases, especially in the old age group. Intrauterine adhesion could be avoided. And finally, I'd like to thank you for your time and attention.
病因筛查呢，它主要从绒毛染色体和母体方面进行了分析，然后母体方面它也强调了3维超声在诊断子宫畸形中的必要性，然后也提出了子宫内膜炎它在反复流产发病中的作用，不提倡细胞因子和 anti-HLA 抗体等的筛查，它强调了适度的合理检查RPL 的重要性。那么他还分析了这个复发性流产的治疗，然后分析了孕酮在治疗 RPL 中的有效性，然后再就是分析了免疫治疗，包括 lymphocyte treatment， 还有 prednisone、IVIG、Li Rpl， 还有肌肉细胞刺激因子和 heparin 在复发性流产的治疗中目前是不支持的。那么再就是分析了 PGTA 它在复发性流产中的这个有效性， 是有一定的推荐，但是呢，大于35岁的好像是效果也不是很确定。下面有一个问题，大家如果有疑问可以提问 T.C. 李教授。Thanks, Professor T.C. Li.
T.C. 李教授可以听到你的中文，我可以用中文提问吗？
可能。Yes.
OK. 我想问 T.C. 李教授一个问题：如果这个病人不是复发性流产的话，但是他是一个完全的纵隔子宫，只是一个单纯的一个不孕症的病人，而且不孕症的病史比较短，您建议他做子宫纵隔的切除手术吗？谢谢。
Thank you. I understand the question. If the patient has never had any pregnancy or miscarriage, I don't routinely ask women to have septum removed. So I only select certain patients for removal of septum. Though if a woman has got one or even one miscarriage, I would discuss it. Depends on the circumstances, especially if the product of conception suggests it's a euploid miscarriage. The other thing I often do is if a woman is planning for IVF treatment, in that case, I usually recommend removal of the septum because there is good amount of literature data to suggest that women with septum, they do have about 3 or 4 times increase in the risk of miscarriage. In my experience, if women go through IVF treatment and they conceive, I have to say that their chance of conception is about the same as women without septum. But if they conceive and they miscarry, they will be very upset because they spend a lot of money, the expectation, and knowing that septum increases the risk of miscarriage, I would routinely remove septum in women undergoing IVF. Though I have to say I don't remove septum for everybody. If they have not yet conceived before, no miscarriage, I would discuss leaving the septum behind. Mainly because the literature data suggests that a lot of women would be able to have a normal life birth. But that's my opinion. I know it's a very controversial area. I know everybody would do it somewhat differently. But this is I want to share with you my own personal view, my own bias. I hope that answers your question.
谢谢 T.C. 李教授。我想总结一下 T.C. 李教授，确定一下我是否很清楚您的意思。就是说，对于一个病人来说，如果没有复发性流产的病史，我们不常会建议他切除纵隔。那么，对于一个做 IVF 的一个不孕症的病人的话，即使他没有反复种植失败，你也建议他切除纵隔，因为为了防止他后期的复发性流产，是不是？好，谢谢您，非常感谢。
谢谢 T.C. 李教授 ，Thank you.
Thank you so much.
今天上午的第一个 session 呢，我们就到此结束。那么下面。